I'm Hugh Calkins. I'm a professor of medicine at Johns Hopkins and director of the EP program and also the ARVD program. I also founded the ARVD program at Hopkins 26 years ago, and it's a pleasure to speak with you today about PKP2 ARVC. I should note that we are now moving to a new way of thinking about ARVC. Instead of thinking about ARVC as a broad set of conditions, we now have a gene-first approach where we think about PKP2 cardiomyopathy versus desmoplastic cardiomyopathy and so forth. So we're moving to a gene-first approach to thinking about these diseases. Now, over the next 10 minutes, we'll talk a little bit about the unique considerations for people with PKP2 cardiomyopathy. We'll talk about disease progression and treatment. We'll also talk about future therapies for this condition. So let me start talking about the unique considerations of PKP2 cardiomyopathy. So I think it's important to realize that PKP2 cardiomyopathy is the most common type of ARVC, about 40% of all cases, and we have a huge amount of experience worldwide with PKP2 cardiomyopathy. It's also classic right-dominant ARVC. The right ventricle is involved first, and the left ventricle is only involved in the late stages of the disease. When diagnosing this condition, we can use the 2010 diagnostic criteria. They're applicable. In addition, we have a risk calculator that can be relied on to estimate risk of any VT or a malignant VT over time. And this type of ARVC is highly exercise dependent. Now, PKP2 is one of the desmosomal proteins. These desmosomes hold cells together. And a simple way of thinking about ARVC is if you exercise a lot, the right ventricle stretches, the wall stress goes up, the pressures go up, and you rip these cells apart. They have bad glue, bad volts. You rip the cells apart, and that's what causes the condition. Now, that's a very simplistic way of thinking about ARVC, but I think it's quite applicable and a useful framework. Now, when it comes to diagnosis, as I said earlier, we rely on the 2010 diagnostic criteria developed by Frank Marcus in 2010. When one looks at the variables that need to be considered for diagnosis, it's important to note that we no longer rely on epsilon waves or single average ECGs, but the rest of the criteria are accepted today and continue to be applied worldwide and can be relied upon. Now, here's a typical EKG of a patient with PKP2 ARVC. You can note the T-wave inversions in the right precordial leads, V1, V2, and V3. That's a major criteria. If it's just V1 and V2, it's a minor criteria. Terminal activation delay, the time from the S-wave back to baseline, more than 55 milliseconds, is a minor criteria. So this EKG alone would give a patient one major and two minor criteria towards the disease. So if they had more than 500 PVCs, then they'd meet the diagnostic criteria. Again, to get the diagnosis, you need two major or four minor diagnostic criteria. MRI is a great way to look at the heart size and function. It's a great way to help evaluate structural disease in ARVC and to look at the parameters for RV size and function and LV size and function. It's also the most common reason for overdiagnosis or misdiagnosis of ARVC, oftentimes because of a wall motion abnormality caused by pectus or a tether, or because the reader sees fat and inaccurately thinks the presence of fat means the patient is ARVC. It's important to note that fat is not in the diagnostic criteria for ARVC. We're really looking at myocyte loss and fibrosis. Now, when you think about the natural history of PKP2 ARVC, it's important to note that the disease does not present until puberty. About 12 or 13 years of age is the youngest I've ever seen a patient with ARVC. The average age of presentation or diagnosis is between 31 and 34. And then over time, it can really present at any age as late as 70, 80, or 90. So there's no upper age limit for when your ARVC can show up. In general, the earlier it shows up, the more severe disease you have and the worse long-term outcome you will have. So a 14-year-old with severe ARVC is going to have a very different clinical course than someone who's 75 or 80 and shows up with ARVC. Now, when it comes to predicting risk of VT or VF, the decision about should you get a defibrillator, we now have risk calculators for ARVC that can be applied to PKP2 ARVC. And if you go to the website, www.arvcrisk.com, you can plug in your variables and figure out what your 5-year risk is. And this is a very useful framework to begin to think about the big question about, do you have a defibrillator implanted? Now, once the defibrillators have been implanted, or even if a defibrillator hasn't been implanted, the question is, how do you minimize symptoms or ICD shocks? How do you reduce the chance of a sustained ventricular arrhythmia? Clearly, the most important thing you should do is stop exercising or dramatically reduce your exercise. Competitive endurance sports are strongly discouraged in this condition, which is highly exercise related. We also recommend you take beta blockers and antiarrhythmic medications if you continue to have a high burden of PVCs, non-sustained VT, or sustained VT on a beta blocker alone. The antiarrhythmic drug we prefer most is flecainide. There's been prospective randomized clinical trials showing that it's effective at reducing the PVC burden. We've also just published a large paper in over 200 patients showing that flecainide is safe and effective for most patients with ARVC, particularly PKP2 ARVC. If antiarrhythmic medications don't control these arrhythmias, the sustained ventricular events, that's where catheter ablation comes in. When you think about catheter ablation, it's really important to go to an experienced center that has experience in ARVC catheter ablation, because you'll require both an endocardial and epicardial approach to get the best results. And this procedure is remarkably safe and quite effective, despite the complexity of the procedure. Again, it's important to have a skilled operator. Now we'll move on and talk a little bit about disease progression and treatment options. I think the important thing to recognize is that ARVC, or PKP2 ARVC, is progressive. No one's born with it. It takes 12, 13, 14, 30 years for it to develop. And once it develops, it continues to progress. It continues to get worse. Again, it's going to progress slower if you reduce your exercise. But we've shown in clinical trials that, yes, it's a progressive disease. If you look over 5 to 10 years, the RV function goes down, the RV dilates, the LV involvement begins to appear. And I think anyone who feels this is not a progressive disease is uninformed. When we looked at our data, we found that over time, at least 49% of patients will develop some evidence of heart failure. This doesn't mean 49% need a heart transplant, but 49% will begin to show some evidence of heart failure. Could be swollen feet, increased pressures in your right ventricle, and so forth. So that's important to recognize. Now, when it comes to preventing progression of ARVC, or how do you slow progression, again, it's all about exercise, reducing the amount of exercise you're doing. Don't do competitive endurance sports. There's lots of scientific data showing that cutting back your exercise will reduce your need for a transplant, will reduce your development of heart failure, and also has the added benefit of reducing ventricular arrhythmias. We recommend beta blockers in pretty much all patients with ARVC. And then we recommend heart failure medications like ACE inhibitors, ARBs, mineralocorticoid medications, as well as drugs like Entresto for patients with moderate to severe RV or LV dysfunction. Clearly, when a patient develops severe RV dysfunction or biventricular dysfunction, in addition to be followed by an electrophysiologist, you should involve your heart failure expert, because it's very important to be followed carefully, to have your medications optimized, and then to pick the right window when you will need a heart transplant if that is the case. We found that metabolic stress tests are a very useful parameter, that once someone gets severe RV or biventricular disease, we rely on metabolic stress tests to help us determine when is the right time for a heart transplant. Now we'll finally just comment on future therapies. And when you think about PKP2 ARVC, the exciting thing is that 3 companies are working on gene therapy approaches to PKP2 ARVC: Tenaya, Lexeo, and Rocket. Each of these companies has clinical trials that are enrolling. The early data has been encouraging in terms of safety and efficacy, but it's too soon to draw any firm conclusions. I know enrollment's underway in all of these clinical trials, so we'll be eager to see the results, hopefully in the near future. I would comment that certainly mouse models have shown that gene therapy is remarkably effective, both in reducing arrhythmias and reducing fibrosis development over time. So let me just conclude that PKP2 ARVC is the most common form of ARVC. We know a lot about it. It's right dominant. It's exercise related. You can use the risk calculator to assess the risk of a sustained ventricular arrhythmia. It's progressive, and progression can be reduced dramatically by reducing exercise. And gene therapy is being developed. Hope is on the way. So we're all extremely excited and optimistic that this will prove to be a curative approach going forward. So I'm going to stop there, and I appreciate the chance to speak with you today.
This video is part of a series of educational videos developed by the Genetic Cardiomyopathy Awareness Consortium and brought to you by the DCM Foundation. Our goal is to connect you with the leading experts in the field of cardiomyopathy to further your understanding of this disease and to provide resources to help you manage your care. Thanks for watching.